Бих искал да открия четвъртата поред сесия, която е посветена на диастолна функция, ляво предсърдие и сърдечна недостатъчност. Имам удоволствието сред нас да бъдат онлайн лектори, които имат огромен както практически, така и теоретичен опит. Dear Professor Sengupta, I'd like to open the session and please be welcomed for left atrial deformation and left ventricle diastolic function. Please be welcome. It's our pleasure to be with us.
Thank you so much. My slides are visible. Are the slides visible?
Yes.
Yeah, perfect. So today I'm going to take you all about understanding the left atrial function and can we correlate with the diastolic dysfunction concept. Now, left atrial function assessment can be done by looking at the left atrial strain. And left atrial strain has come up in recent times, a lot of interest. And there are a few waveforms. And we have to understand that when we do a left atrial strain, we generally look at the apical four-chamber view, looking at this at the left atrium and try to trace it, and again also get an apical two-chamber view and try to trace it. And you get different kinds of waveforms, and it is very important to understand what these waveforms mean. So this is a tracking of the left atrium, and you get this is the aortic valve closure, and the first wave which is seen is nothing but the reservoir strain, which is also called the peak atrial longitudinal strain. The second is the conduit strain, and third is the booster strain. So these are the three waveforms which are seen, and the maximum research has now gone into looking at the main reservoir strain, which is also called the PALS, peak atrial longitudinal strain. And the booster strain is called the peak ACS, peak atrial contraction strain. But you should have to understand that this is the reservoir strain, this is the conduit phase, and this is the booster strain. Now, there is another concept which is the left atrial strain rate, and you get this nice beautiful waveforms whenever you track the left atrium. And this is nothing but the systolic strain rate, this is the early diastolic strain rate, and this is the late diastolic strain rate. Now this waveforms coincide with the inflow pattern where we looking at the mitral inflow, that is the E and A waves. So two most important thing is to understand what is left atrial strain and left atrial strain rate. Now, remember the left atrial strain and left ventricular strain are very important, and they go hand in hand because there is something called left atrium and left ventricle coupling. So whenever the left ventricle is contracting, the left atrial expands, and whenever in a phase of left ventricular diastole, the left atrial contracts. And this coupling is needed to understand the pathophysiology of various disease morphology. Now, if we look at the left atrial strain in comparison with the left ventricular strain, the and this is a study which came back in JACC imaging. They have correlated the left ventricular strain values with the left atrial strain values. So this is a normal, and we discussed yesterday the left ventricular global longitudinal strain is around -19. Anything more than -19, -20, -21 is normal. And the left atrial strain are always in the positive phase because they're moving, they're relaxing when the LV is contracting. So the positive is more than +35. So in normal, it is around +37. And as the grading of LV diastolic function increases, so this is grade 1, where the strains go down, the left atrial strain also goes down. In grade 2, it becomes lesser, it even become lesser in the various phases. So there is a left atrial and left ventricle coupling, and this has to be understood in a very important manner. Now, this was a study by Morris in Jack imaging, which looked at the normal ejection fraction persons diastolic dysfunction. So these were around 500, more than 500 patients who were at a high risk of diastolic dysfunction, those who were hypertensive, diabetic, and coronary artery disease. And we know that in the guidelines of diastolic dysfunction, we have the septal E prime less than 7, E prime on the lateral side less than 10, an average E by E prime of more than 14, a TR velocity of more than 2.8, and a volume index of 34. So if all these four were used in this group of cohort, we had only 13.5% of patients who were having identified with diastolic dysfunction. So so we are talking about this people who were asymptomatic, who had a normal EF, who were at a risk of having a problem. But when you added a left atrial strain value, then this diastolic function identification increased. And when we added an LA volume index, which is less than 34, that means the parameters are going down, then the risk of patients having an NYHA class symptoms, a peak, the PCWP or a heart failure hospitalization was increased. So the point is there is an incremental value of LS strain which is still not been incorporated in our guidelines. So let's discuss this concept by case. So this is a patient who is a 69-year-old female, obese, BMI of 36, sedentary, has NYHA class 3 symptoms, symptomatic with breathlessness, non-diabetic, non-hypertensive. There is no asthma, no COPD, and has been diagnosed to have hypothyroid. So hypothyroid on thyroxine and obese patient, and the patient has NYHA class 2 symptoms. An angiogram done a couple of years back was normal. So we have this HFA-PEFF score, which has been given to identify the presence of HFpEF or diastolic dysfunction in a group, and this has a pretest probability of diastolic problem, and it uses morphology like LA volume, LV mass, the RWT. There is function assessment by E prime, E by E prime, TR velocity, and the global longitudinal strains of LV, and there is a biomarker which is the BNP, anything more than 35, or anti-BNP at 125. This is being utilized extensively in all clinical practice. So in this patient, the LA volume was around 40. Normally, we know anything more than 34 was high. So this was positive. This is at rest. We got the LV mass. It was 99, and the RWT was around 0.42, which is a normal. So this parameter was not there. You had an LV global longitudinal strain, which was absolutely preserved. It was minus 20. Remember, the patient had symptoms. She had breathlessness and NYHA class 3. So this also doesn't satisfy. So an E by E prime of 11.7, as we know that anything less than E by E prime of less than 8 is normal, anything more than 14 is abnormal. So this was indeterminate or a borderline condition. But this was not normal, this was borderline. And the TR velocity was 2.18. Again, it was not satisfying. So this patient, we got the NT-proBNP, and the values are shown here. So patient's NT-proBNP was elevated, 397, which is very high. So these are the values, this scoring system which has been given. So if the BNP is more than 80, you get 2 score. If it is between 35 to 80, you have 1 score. If the NT-proBNP was 220, it scores 2. So this gets 2 score. So now our patient scoring system of this HFA-PF2 scoring system, it is unlikely if the score is less than 1 or equal to 1, or if it's probably if it's more than 5. Our patient had 2 plus 1 plus 2, so almost 5. So very high probability of having an issue. So, but if you remember, the patient was symptomatic, E by E prime was not there. Can we do something else? There is something called diastolic stress test. where we exercise the patient and try to look at the values of E by E prime going more than 50, or if the TR velocity goes more than 3.4, or you also do an invasive CAT test and look at the PCWP of more than 25 on exercise. And these are the feasibility studies which have shown up that at peak exercise, these levels go as high as around 54 to 49%. But this is, this is a very difficult entity, and we may not have an access to exercise. It may be robust, it may be cumbersome. So can we do something more? And the answer is LS strain. So we looked at the left atrial strain of this patient. You can see again nice curves. And let me show you that the left atrial strain has a very good correlation on exercise with the peak VO2, and this was a circ imaging study of as much as 308 patients. So looking at these values, it has been shown that the diastolic function assessment also has a good correlation with the left ventricular filling pressure, with even with exercise. And so we made this patient exercise, and this is on a CPET study. This is the ECG at rest, and this is at stress, and we got the peak VO2 of around 7.7, and also V by VCO2 of 36. Now, okay, whatever happened? Let me move ahead. It is just loading. Okay, I think I have to again share the screen. 1 second. The uh, the presentation got just stopped. So my point, what I'm trying to tell you is that it is very uh, robust to have LS strain assessment, and it can be done easily on a bedside. I'm just opening up my images. They are there, already there. Just 1 second. And here I am. Yeah. So I hope you can see it again. I will just go directly to that case. Uh, so this patient was made to exercise, and on exercise, the peak TR velocity increased from 2.18 to 3.07. The E by E prime, which we want more than 15, went into 17.4. And the HFF PEFF score increased from 5 to 7. But the point is, this is a very interesting article which came in JACE, which has correlated that LS strain correlation with this score after exercise. And as you exercise this patient more, the LS strain goes on decreasing very, very importantly. And the prognosticate value of LS strain in HFpEF in this group of 300 patients over a period of time has given us a cutoff value. So if the cutoff value, which this group of patients, they behave poorly over a period of time, if they are followed up over around 3.5 months of time. So there is a concept of dynamic LAS, and this is the patient we have been looking at, and on LAVY on baseline was 32, LV mass was 99. We did a leg raising test, and on LS strain on leg raising test also changed. At rest it was 18, at leg raising it improved to 24, and LS strain rate also decreased. So again, an article in JACC Imaging looking at the influence of passive leg raising test on LA volume as an LA reservoir strain and LA booster strain, showing that these are hemodynamic changes which occur after exercise, looking at it in a group of cohort of patients who are supposed to be HFpEF. So this patient had rest, didn't have TR. Let me go ahead. I don't know why is it not moving. I'm sorry, extremely sorry that there is some problem with my sharing, but I have only few slides more to show, which makes you understand that left atrial strain becomes a a very robust parameter when you uh, at rest and also after exercise in identifying a group of patients who are in the borderline phase. One second, I'm again sharing. It is already there. There is, right, it has come, and a couple of few more slides. So on exercise dynamic LS strain, it has been proposed that if there is a cutoff of 16 was given, so if there is on exercise, if the values go beyond 16, less than 16 in on an LA strain, then it has got prognosticate value. So what I would like to tell that LA strain can be done. It should be done in every patient. The normal, we generally look at the peak ALS, that is the LA reservoir strain, the peak atrial nodular strain, and normals are something more than 35 in the positive plus 35. And there is a lot of coupling between LA strain and LV strain. But whenever you are suspecting heart failure with preserved ejection fraction, there are lot many scores which have been given, but you should always add on the LA strain value at rest, and if possible, you can also add on an exercise-induced LA strain, a cutoff of 31. Anything less than 31 at rest has prognosticate implication. And if you exercise this patient on a CPET, then if it, on exercise there is a decrease in the LS strain, it also gives an idea that the LA is getting compromised. Thank you so much.
Thank you, Professor Sengupta, for your nice presentation. You convince us that AOA and LV have very close interactions between them. And I would I like to ask a question for AOA strain. Is it enough in patients with indeterminate diastolic dysfunction to perform AOA strain at rest, or we should prefer diastolic stress test?
Yeah,
Is it
so
changeable?
right. So I think it's a very good question. So in indeterminate patients where the E by E prime is between 18 to 8 to 14, the guidelines do say that diastolic stress test can be done. Yes, you can do it, and if the E by E prime goes high and TR velocity gets augmented. But I will suggest that every patient of suspected diastolic dysfunction, if there is indeterminate, please trace the LA and try to get a strain analysis. If the strain values are less than 30, 31, then you are dealing with a problem. You can also do a diastolic stress test and look at the strain, LA strain also in this group of patients. And there are mixed reports. I'm telling you that few patients, the LS strain improves. So the problem is not there in the left atrium. So there is a concept called isolated left atrial mixopathy, where everything is normal, but still the patient has a problem of HFpEF. In those patients, the LA strains go down even. So you can surely, the guidelines tell you should do a diastolic stress test, but the point is you should also try to look at the LS strain because it hardly takes a 1 minute time to get the LS strain.
Thank you. May we have some questions from the audience?
I don't see any questions, but may I ask you something, a short question? We used now to perform exercise stress strain left ventricle with, for example, hand grip test. Is it possible to be performed also for left atrium? And how do you validate your exercise testing in such patients?
Right. So the ideal exercise testing is either on a bicycle mode or by doing a bicycle CPET, or you can also do a treadmill by doing a modified Bruce protocol or Norton protocol. But if you don't have it, if you don't want to do it, there are 3-4 ways you can do it. You can have a passive leg raising test where you can make 30 times leg raising test. You can also have a hand grip maneuver, or we also do a 6-minute walk test. Once you do either of them, if you are basically changing the loading conditions. To be precise, the preload and afterload changes. And these are hemodynamic changes, and these do alter the left ventricular GLS and also the left atrial GNS. So if there is any alteration, as one of my examples show that on a leg raising also there was an augmentation of the LS strain. So we can do it on a bedside if you don't want to subject the patient to a bicycle or a treadmill exercise.
Thank you, Professor Sengupta. Thank you. We move to the next presentation. It's a pleasure to present Professor Donau from Ponchhelm Hospital of Rennes. Professor Donau, please.
Yeah. So thank you very much. Thank you for your kind invitation. So it's my pleasure to speak after Dr. Sengupta about the value of LS strain. So I will try to convince you that it's a way to best assess our patients and sometimes to understand symptoms, as it has been discussed previously, but also the risk of arrhythmias and the risk of stroke. Of course, you can go back to the guidelines or to the recommendation papers that have been published by the EACDI, and you probably know about this manuscript that has been accepted for publication at the beginning of the year about the source of emboli. And when you look at this paper, you see that there are many sources of cardiac emboli, and one of them, the major source of cardiac emboli, is the atrial fibrillation. So it means that when we have a patient with a stroke, when we have a patient with palpitations, we have to check for the probability that this patient could have atrial arrhythmias. And for that, I think that it is quite interesting to look at LS strain. I will try to convince you. Of course, before that you look at the LS strain, you have to check many other things. For instance, the presence or not of a PFO associated or not with an atrial septal aneurysm. So these are things that you are already doing in your clinical practice. And it's very important when you have a young patient who did a stroke. But the major problem is that you have to make sure that the patient that you see for a stroke or for palpitation has or don't have a risk of atrial arrhythmia. Most of the time, you don't see the arrhythmia when the patient is hospitalized or when you see the patient in the emergency room. So there are many problematic here, and we can discuss, for instance, the implementation of Holter monitoring, long-term Holter monitoring, but there are studies going on. It's quite expensive. Then we cannot provide a long-term Holter monitoring to every single patient who did a stroke or every single patient who had palpitations. So we have to define who are the good candidates for this long-term Holter monitoring. And perhaps for that, the assessment of LA size and LA function could be useful. I will try to convince you. Of course, when you look at the LA, there is a remodeling of the LA when you have an arrhythmia. It means that you have an electrical remodeling, and this electrical remodeling associated with an arrhythmia is associated with the LA contractile remodeling and the LA structural remodeling. So it means that you can look at LA size, you can look at LA function, and if you are able to assess LA size and LA function, you are not that far from the electrical remodeling, so you can estimate the risk that the patient has some degree of LA electrical remodeling. But first of all, you have to start by looking at LA size, and it's very important to report in every single patient the size of the LA. We know that the size of the LA is correlated with the risk of cardiovascular and non-cardiovascular deaths. We know that it's associated with the risk of arrhythmia and the risk of thromboembolic complications. And when you are in clinical practice, you really have to focus on the biplane LA volume reported according to the surface, the body surface area. So you have this normal value of LA volume greater than 34 milliliter per meter square. So it's very important to report on this LA volume and to have in mind that larger is the LA, higher is the risk. But also it's important to know that structure is sometimes changing after the function, and probably the assessment of the LA function is more sensitive than the assessment of the LA anatomy when you want to assess the risk of a patient. But before that I move to the function, I wanted to show you this important paper, at least according to me. This is a paper that has been published long time ago at the Mayo Clinic, and it shows that, of course, the normal value of LA size is lower than 34 milliliter per meter square, but the risk is even higher when you are over 40 milliliter per meter square. And I think it's very important to have in mind this cutoff of 40 milliliter per meter square, because it's much more associated with the risk of events than 34 milliliter per meter square. And then before that I move to function, I wanted to emphasize the quality of the assessment of the LA that you can have when you do a transthoracic echocardiography. And it's very important to have in mind this slide. This is from a paper that has been published at the end of last year. And in that paper, we emphasize the importance to optimize the long axis of the LA to make sure that you don't underestimate the size of the LA. So you don't consider the pulmonary veins, you don't consider the left atrial appendage, you just consider the LA when you measure the LA volume, but you have to optimize the long axis of the LA for these measurements. And you have to keep in mind that the long axis of the LA is not the same as the long axis of the LV, which means that you might have to record images that are dedicated to the LV and images that are dedicated to the LA. Also, when you assess the LA function, it has been discussed previously, but you have three components of the LA function. The reservoir function is the easiest to assess when you consider LA strain. The Condry function can be measured as well. And the booster pump function is probably the more important, but the more difficult to assess precisely. This is an assessment of the LA strain in apical 4-chamber view. So you see that I have an image dedicated to the assessment of the LA, and you easily see the LA reservoir function during LV systole, the LA Condry, and when you are back to zero, this is the fact, this is the in relations with the LA booster pump function. So as I told you, it's important to optimize the long axis of the LA for the assessment of the LA volume, but also for the assessment of the LA strain. And according to volume, if you are not able to optimize this long axis by 2D, you can still record a 3D data set of your patient, and then you will be able afterwards to optimize the long axis of the LA to optimize the measurement of the volumes. But back to the LA strain, so you record a 4-chamber view and a 2-chamber view, and according to these images that you can easily obtain, you can have the assessment of LA strain in both views, and the average between these both views provide you important information in regard to the risk of arrhythmias, as it has been said for the assessment of patients with heart failure with preserved ejection fraction. It has been demonstrated as compared to anatomic pathology, but also according to the assessment of the presence of fibrosis by CMR, that there is a huge correlation between the decrease in LA reservoir function and the presence of LA fibrosis. So an indirect way to assess the presence of LA fibrosis is to look at LA strain, and it has been reported mainly about the assessment of LA reservoir function. I wanted to share with you this paper that I like that we did in our team. This is a study that has been done in not patients, but subjects that are around 65 to 70. These subjects, are retired, and they use their free time to do a lot of exercise. They are cycling a lot. In Brittany, where I'm living, there are a lot of people from these ages who like cycling on the coast. And then they are athletes because they are practicing bicycle more than 2 hours per day, every week. And then they are really clear athletes. But among them, some might develop paroxysmal or permanent atrial arrhythmias, and some will not. And it's pretty complicated when you see these people who are 65 to 70, who are in good shape, who are asymptomatic, who are cycling a lot, to predict the ones who will be able to develop an atrial arrhythmias and who are the one who will not develop any atrial arrhythmias during the follow-up. And when you look at the value of LA size or RA size versus LA function assessed by LA strain or RA strain, you see that you are much more efficient in for the prediction of the risk of arrhythmia when you look at LA reservoir function as compared to LA volume. And that's quite the same for the right atrial strain as regard to right atrial volume. You see in green the patient who will never develop any atrial arrhythmias during the follow-up, and in red the patient who developed an atrial arrhythmia. And this is quite clear that there is a gap between the ones who will develop the arrhythmia and the others when you consider the LA strain, and the cutoff value was quite normal, about 40%. And there are many papers, at least 10 to 15, who looked at the value of LA strain for predicting the presence of atrial arrhythmia or risk of cardiac emboly source of the stroke. And it seems that you can consider the assessment of LA strain in addition to the SHADS or to the SHAD-VASC to improve your capability to predict the risk of stroke. And there are also studies who demonstrated that LA strain has an additive prognostic value to SHAD-VASC, or can be used in instead of SHAD-VASC because it's more powerful than the SHAD-VASC. Also, when you have a patient that has been treated by RF ablation for the atrial arrhythmia, you can use the LA strain to predict the risk of recurrence, and there are something like 10 papers that have been published providing quite always the same cutoff for the LA reservoir function. And if the LA reservoir function is below 20%, the risk of recurrence of the arrhythmia is quite important. In opposite, if after the RF ablation, the patient has a LA reservoir function greater than 20%, the risk of recurrence of the atrial arrhythmia is much lower. So it's quite convenient when you follow patients that have been treated for their atrial arrhythmias. And if I come back to stroke, you see that in that large study performed in more than 500 patients by Tom Marwick's teams, it has been shown very nicely that the LA reservoir function is quite powerful to distinguish the patients who have some degree of atrial arrhythmias and the one who don't have any atrial arrhythmias. And you see that the cutoff value for the LA reservoir function assessed by LS trend is again about 20%. In that case, it's 21.4. But you see that if you have a LA reservoir function that is below 20%, the risk of arrhythmia is quite high, in opposite to patients who have a LA reservoir function about 40%, where the risk of atrial arrhythmia is quite low. This assessment of LS trend is quite robust. It has been demonstrated, for instance, in that study when you use the TomTech software, but it has been also demonstrated when you use the GE software. So the measurements of LS trend is a little bit less robust than the GLS that you can record for the LV, and that will be discussed by Victoria Delgado just after me, I think. But the assessment of LS trend is something that is quite convenient, quite rapid, and applicable in clinical practice. So my conclusion are that we have to report about the measurement of LA volume. That's mandatory, that's in the guidelines, and that's very important to predict the risk of events. But in addition to this precise measurement of LA volume, in few seconds, you can add the assessment of LS trend. At least the LA reservoir function can be reported, and it's something that is providing something more than the assessment of LV trend. So please consider this tool. If you are below 20% for the LA reservoir function, you are at risk for arrhythmias. If you have a LA reservoir function about 40%, you are quite normal and the risk is very low. So please consider a more precise assessment of the LA for the heart failure patient, as it has been discussed previously, but also for the risk of arrhythmias and the risk of stroke. Thank you very much.
Professor O'Donnell, thank you for that great presentation. I'm waiting for some questions online. I have a short question for you. I'm very interested. What do you think about which is the first function of LA that is changed in athletic heart, not with arrhythmias, just athletic heart? Is it the contractile? Is it reservoir?
Actually, it's not studied that much in young athletes, but at least in athletes like the one that I showed you, about 60, 70 years old, the LS trend is supposed to be normal or supernormal. So usually you have a LA reservoir function that is much higher than 40%. But that's also the case in young people. Usually you can have in patients that have a normal size of the LA, the reservoir function that is close to 60% sometimes. But always we have to keep in mind the fact that when we measure this trend, this is true for the LV, but it is true also for the LA, these measurements is impacted by the load, but also by the size of the LA. So if you have an increase in size of the LA, you will have a decrease in LA reservoir function. And also, if you have an increase in blood pressure, you will have a decrease in LA strain. So you have to integrate the size of the LA, the load, and all these parameters have to be taken into account. So in the young athlete, usually the LA size is normal, the load is very low, and then the reservoir function is very high.
Thank you. That was a great answer. We have a question online. How to assess LA strain if atrial fibrillation, irregular wave?
So in case of atrial fibrillation, it will be the same for LV, but there is a decrease in function related to the fact that there is no booster pump function anymore. But if you have the last version of the GE machine, actually, you can measure the LS trend quite easily in patients with an atrial arrhythmia. But it's not that true if you have an old version.
We have
Hi,
some question from Professor Sengupta.
Right. Hi, Professor.
Hi.
How are you?
Mm,
How are you?
thank you.
I was just thinking, I mean, there is always a challenge of looking at the LA when it is big in size. Do you think we should index it? I mean, how about the concept of indexing the LA strain?
Yes, that's an interesting question. We can say the same for the LV actually, and I'm not sure that there are so many investigators who looked at this indexation of the LV or the LS strain. We did for the mitral regurg actually, and of course, if you normalize the LV strain at least by the size of the LV, you increase the predictive value of your strain data set. So yes, this is something that can be tested, but I don't think that there is anything published on that topic.
Yeah, I mean, because I've been thinking about it. Maybe we will talk about it.
Yeah, it's a good idea, yes.
Right, gotcha.
So if there is no other questions, it's my pleasure to invite Professor Victoria Delgado from Leiden, and please be welcome.
Thank you very much for the invitation to participate in this echocardiography days. It would be very nice to meet you all, but the circumstances make us still be patient and be here online, which is also a pleasure. So after the excellent talks by Dr. Sengupta and Dr. Donal focusing on the left atrium, I'm going to focus on the left ventricular function during atrial fibrillation or in patients with atrial fibrillation. And these are my disclosures. So why is assessment of left ventricular function important in atrial fibrillation? So as you have been seeing in previous talks, the focus is mainly the left atrium because that is the underlying substrate for the arrhythmia. And we focus mainly on left atrial remodeling in anatomy and structure and function, and other sources of complications of atrial fibrillation, such as left atrial appendage or left atrial thrombus. But we also need to remember that one of the main factors affecting the remodeling of the left atrium is sometimes the left ventricle. And there are several other causes that can impact on the structure and function of the left atrium, which is just a victim of those entities. And atrial fibrillation is secondary to them. So it's important to assess as well the left ventricular size and geometry, the heart valve morphology and function, and the right heart chambers as well. And this is collected, or it is highlighted in the 2020 ESC guidelines of atrial fibrillation. Atrial fibrillation can be known, but is actually quite a rare entity, and usually is very much related to aging, genetics, male sex, and ethnicity, but also there are several other risk factors such as coronary artery disease, heart failure, valvular heart disease, hypertension, diabetes, or chronic kidney disease, smoking, or obesity that are going to impact on the left ventricular systolic function. And we know that if these risk factors are not well controlled, the risk of having atrial fibrillation increases significantly. So what is important to assess? So we know that by assessing left ventricular function, we can already predict as well the risk of stroke, of ischemic stroke, and particularly that increases significantly when we have a moderate or severe left ventricular dysfunction. But it's important to remember that the risk of a stroke is also increased in patients with HFpEF. And this recent study published in Heart last year, including 5,625 patients hospitalized because of acute heart failure. These patients were divided according to the ejection fraction, and there were almost 60% of patients with reduced ejection fraction, 25% of the patients with HFpEF with preserved ejection fraction, and 16% of the patients with mildly reduced ejection fraction. You can see that the frequency of HFpEF increased with age and was more frequent also among female. And what you can see in this Kaplan-Meier curve is that the risk of stroke was highest among patients with HFpEF with and without ejection fraction and reduced with atrial fibrillation, sorry. And that you can see that the presence of HFpEF is significantly associated with the occurrence of a stroke, either with atrial fibrillation or without atrial fibrillation, and that is important. And this is why the CHAS-VAS score that is now summarized in the ESC guidelines consider the C as a congestive heart failure based on symptoms and irrespective of ejection fraction. So ejection fraction is no longer a parameter to be considered in the CHAS-VAS score. But another question is if ejection fraction is the best parameter to use, because we know that all the risk factors that are associated with atrial fibrillation, such as hypertension, obesity, diabetes, coronary artery disease, may be present in patients who have a normal ejection fraction, but if we measure more sensitive parameters of left ventricular systolic function, such as global longitudinal strain, we can see that global longitudinal strain is reduced. And that is related not only to changes in the chamber size or the presence of areas that are akinetic, but also to the presence of cardiomyocyte death and reactive fibrosis. When we have cardiomyocyte death or there is a mechanical, ischemic, or metabolic injury, we have first myocyte death, and these myocytes, this apoptosis, will be replaced by profibrotic factors and by fibroblasts. And this mechanical, ischemic, and metabolic injury can also impact directly on these fibroblasts that become activated. They proliferate and differentiate to a secretory phenotype, this myofibroblast, and they produce or activate the pathway of collagen, leading to a diffuse deposition of highly cross-linked collagen fibers that lead to myocardial interstitial fibrosis. This myocardial interstitial fibrosis is the first marker of the remodeling, and when there is the cardiomyocyte death and there is the replacement fibrosis, is the scar that it will be no longer reversible. So when we have an interstitial heart disease, or there are changes in the interstitium, what we are going to have is an increased cardiomyocyte afterload and preload from the collagen stiffening. There is a decreased perfusion reserve from the perivascular fibrosis and the capillary refraction, and less access to capillaries from interposing collagen. And there is an abnormal electrical conduction or risk of reentrant arrhythmias. At this stage, the ejection fraction can be still normal, but you will see that the diastole probably is going to be abnormal, and one of the reflectors can be already left atrial remodeling, as well as Dr. Donal and Dr. Sengupta have indicated, and global longitudinal strain is going to be reduced. When there is already a progression of this remodeling and there is already overt systolic and diastolic dysfunction, ejection fraction still can be normal, but most of the times can be reduced. Diastole certainly is going to be abnormal, and global longitudinal strain is going to be abnormal. And when there is overt heart failure, all of them are abnormal. At these three different stages, the question that we are going to answer is different. So at the earliest stage, the question to answer, particularly related to atrial fibrillation, is this patient going to have an increased risk of atrial fibrillation and complications of atrial fibrillation because of early detection of LV dysfunction or specific etiologies that may impact on the left atrium? When there is already abnormal diastole and global longitudinal strain, we are gonna be more focused on risk stratification as well when there is over heart failure. And in the case of early disease and estimation of risk of patients of having incident heart atrial fibrillation, you can see in this study, including 680 patients without prior atrial fibrillation and without other cardiovascular risk factors, you can see that those patients who have a global longitudinal strain more positive than -15 around, let's say that they are impaired, these have much higher risk of atrial fibrillation. And actually, in the multivariate analysis, global longitudinal strain per 1% decrease is associated with increased risk of atrial fibrillation after correcting for other variables such as age, obesity, hypertension, antihypertensive treatment, coronary artery disease, LV mass index, and relative wall thickness. And this study also showed that having an impaired global longitudinal strain and an increased left atrial volume index was associated with a higher risk of developing atrial fibrillation. And on the chi-square analysis, global longitudinal strain had incremental value over ejection fraction and left atrial volume index. But global longitudinal strain eventually is a sort of indirect measurement of what is happening in the structure of the myocardium. And we know that magnetic resonance has been an important imaging modality for evaluation of patients with atrial fibrillation who are undergoing radiofrequency catheter ablation. As Sir1 previously shown, the group of Utah has correlated the assessment of myocardial fibrosis on CMR with a longitudinal strain of the left atrium. And there are several measures that we can do with CMR. We can assess the pulmonary vein anatomy. We can assess the presence of diffuse fibrosis, of reactive fibrosis, the early stage of the remodeling. We can assess LV function and mass. And we can assess the presence of macroscopic myocardial fibrosis, so the replacement fibrosis. And in this study, the authors showed that the presence of increased extracellular matrix, increased extracellular volume, the diffuse fibrosis, was associated with a higher risk of recurrence of atrial fibrillation. It's not infrequent as well to see patients with atrial fibrillation who have replacement fibrosis, and there are different patterns of replacement fibrosis that we can see on late gadolinium enhancement. We can see the subendocardial following one of the territories supplied by one of the coronary arteries that will be much more coronary artery disease. We can see mid-wall fibrosis that it will be more idiopathic. Etiologies of epicardial fibrosis, as we can see, for example, on sarcoidosis, and the presence of late gadolinium enhancement, whatever the pattern is associated as well with increased risk of mortality in patients with atrial fibrillation. So is it important as well to understand what are the structural changes that lead to a functional abnormality in patients with atrial fibrillation. So with this, I conclude that the assessment of left ventricular systolic function in patients at risk or with atrial fibrillation is important. We focus very much on the left atrium, but we don't have to forget that the left ventricle is sometimes one of the main causes to alter the left atrium. Left ejection fraction is not considered for risk stroke. Instead, left ventricular global longitudinal strain has shown to be incremental to LA volume and ejection fraction to predict the occurrence of atrial fibrillation, but also complications, and myocardial fibrosis assessment for prediction of radiofrequency catheter ablation outcomes and survival has shown as well to be important in patients with atrial fibrillation. And with this, I will be happy to answer any questions that you may have. Thank you very much for your attention.
Thank you, Professor Delgado. The presentation which we delivered was very detailed, nice presentation. Thank you. In clinical practice, is it enough for patients to measure airway indexed volume, and ejection fraction of the left ventricle, and also global longitudinal strain to conclude is this patient at risk for atrial fibrillation or not?
Well, that's a good question. I mean, you cannot evaluate only one parameter. You evaluate the whole parameter. And as I said before, it depends very much on how the patient shows and what are the symptoms. The question is going to be different. So if you have a patient who do not show any structural abnormality on the echo, you may go to more sensitive parameters if you think that that patient is at increased risk of having arrhythmias because has other comorbidities or other risk factors.
Thank you. Any questions from the audience?
I don't see questions online. That was great presentation, really. I was just thinking, do you think is there some clinical value to assess left ventricle function after exercise in patients who are at high risk for atrial fibrillation?
It could be, I mean, in principle, exercise echo is a test that you use when you have patient with symptoms and at rest you don't have any clue or any indication of why the patient may be symptomatic. And then you may perform an exercise echo to see whether there are wall motion abnormalities during exercise, and that indicates to you that is coronary artery disease, or if there is diastolic dysfunction during exercise, and that can lead to an increased risk of atrial fibrillation. So yes, exercise echo is a very good test whenever there is a mismatch between the symptoms of the patient and what you see on the echo at rest.
Thank you. Thank you. If we don't have any questions, we should move for the next symposium. Thank you, Professor Delgado. Thank you for being with us. Have a nice day.
Thank you very much. Congratulations with the Congress.
Thank
Have a
you
very
once
nice
again.
day. Bye.
Bye.
Мога ли да помоля професор Гацов